for that nice introduction. Good morning and good afternoon, everyone. It's really a pleasure to be able to join you for today's session on advancing equity through health system strengthening approaches. So this session really draws on USAID's Health System Strengthening Vision 2030. And USAID really believes that focusing its and other stakeholder efforts on three interrelated outcome goals, equity, quality, and resource optimization, will result in resilient health systems that produce sustainable public health outcomes. I think this is particularly important during the times of volatility, crisis, or transition. And this session will really focus on the first of those outcome goals, which is health equity. So USAID recognizes that the nature of health equity is inclusive, cross-cutting, and integrated, and our vision supports advancing a broad range of activities that can impact the core objective of our work. USAID's Office of Health Systems focuses on the underlying systems issues that impede equity and advance approaches that best support country-led strategies and local priorities for health system strengthening. This means support for context-specific and locally driven solutions that reach the most vulnerable populations. Our focus is on practical application and measurement of systems, tools, and approaches to address barriers to equity. This includes addressing health systems performance limitations, political economy factors, and related health and social determinants. It also includes integrating robust monitoring, evaluation, and learning into activities to maintain a focus on learning and building our portfolio of proven approaches. And it includes strengthening our multi-sectoral approaches, as well as leveraging social sectors to implement integrated programming in the pursuit of equity. Growing evidence indicates that health system strengthening interventions that prioritize reaching the vulnerable and excluded populations can drive dramatic and equitable reductions in mortality. We know, for example, that maternal and newborn health care improves when we ensure respectful care, and this has been an important focus area of USAID for many, many years now. Evidence suggests that ethnic minorities are at a greater risk of experiencing disrespect and abuse during facility-based childbirth. And this risk can increase when we factor in other social determinants such as socioeconomic status, parity, and age. Financial coverage, I think, as we all know, is well recognized as an important factor in health equity, and it continues to be a priority for USAID. We know that people without health insurance are more likely to avoid accessing services, and they are less likely to receive quality care. We continue to invest in evidence-based approaches to universal health coverage and ensuring that the poorest and most vulnerable populations have access to affordable care. And we know that the health workforce plays a really critical role in addressing social determinants of health. Having a professionally trained and effectively deployed workforce is really, really important. Evidence also suggests that community engagement and accountability strategies that have a positive impact on access and quality are central to advancing these types of approaches. We also know that diversity and inclusion in recruitment across professional cadres increases the likelihood and that vulnerable populations will access and receive quality care. USAID's Vision for Health System Strengthening 2030 puts forward several approaches to promoting equity through health system strengthening approaches. These, for instance, include social accountability, social and behavior change, community systems for health, and intentional engagement of vulnerable populations. These four areas, while not comprehensive of ways to enhance equity, are worth emphasizing as important and practical within countries' current health system strengthening efforts. So thank you so much for the opportunity to provide some brief opening remarks. I really look forward to hearing from our moderator, Dr. Anju Malhotra, as well as from all of our panelists today Thank you so much for having me join you today for this session. Nathan, handing this back to you.
Wonderful. Thank you so much, Mai. Excellent opening remarks. It's now my pleasure to introduce the moderator of this session, Dr. Anju Malhotra. Anju is professor of practice at the Johns Hopkins University Bloomberg School of Health and currently seconded to the Global Financing Facility at the World Bank as Senior Gender and Monitoring and Evaluation Advisor. She's also the technical lead on the MAGE project. MAGE stands for Monitoring and Action on Gender and Equity, which is a GFF and Hopkins collaboration to more fully embed gender and equity in GFF's work through a focus on measurement and result. A lot of alignment with things that we've been working on and emphasizing with USAID. Dr. Malhotra is a recognized leader on gender equality, reproductive health, and adolescent rights. She's especially known for her thought leadership on gender and equity, intentional investments, programs, measurement, and evaluation systems. Until recently, she headed UNICEF's work on gender equality, where she developed and implemented the game-changing Gender Action Plan, or GAP, which delivered a focused, inspiring program strategy along with a highly relevant results framework. Finally, Dr. Malhotra has been a key architect of the SDG target and global movement to end child marriage. She established and ran the multi-donor, multi-country global program to end child marriage and has been a foremost expert in advancing the evidence base on child marriage and adolescent health. Dr. Malhotra, Anju, thank you so much for sharing your expertise with us and moderating our panel session today. And that's it from me. Over to you.
Thank you, Nathan, and thank you, Mai, for those wonderful introductory remarks. I'm so delighted to be here today to be part of this panel, as so much of what this panel is focusing on is exactly what I personally and professionally, but also the organizations I'm working with are aiming to do. I would like to give some opening remarks and talk a little bit about the focus on equity and health system strengthening and measurement that is ongoing currently, and also maybe pose some challenges that those of us who are trying to move forward a rights perspective and an equity perspective have faced in the past, and how we may address that going forward. So I've sort of titled my talk as Advancing Equity in Health System Strengthening. Can we go beyond inclusion and voice to power and influence? Next slide, please. So I'm especially excited to hear what Mai had to say, and also the USAID and Bill and Melinda Gates Foundation funding of the Accelerator project, which really it both expresses a vision for health system strengthening that USAID has put forward, and the Accelerator project is trying to take forward. And that vision has looking at better health outcomes at the center, but then looking at how health systems and then these cross-cutting area of equity, quality, and financial optimization is essential for moving them forward. I'm also really excited to see that the Accelerator project has a special focus on West Africa, not exclusively so, but especially where progress lags. And we've seen so many challenges in the last 2 decades in building sustainable health systems, and has a focus on building self-reliance on country capacity, institutions, and expertise. And then, really trying to take a sustainable approach rather than a piecemeal one, where countries are self-reliant in moving things forward. I'm also really intrigued by these 4 pillars, or the 4 approaches that the Vision for Health System Strengthening puts forward: social and behavioral change communication, social accountability, community systems, and the engagement of vulnerable populations. I think these provide a foundational framework for many of us to move forward. So we're grateful to both USAID for putting this vision forward and for organizations that are working on projects such as the Accelerator Project, both globally and nationally within their countries. Next slide, please. I find this approach forward-looking on several key fronts, and many of these points resonate especially with us because the MAGE partnership that Nathan mentioned, that I am a part of during my secondment from Hopkins to the Global Financing Facility, are very, very much central also to the MAGE project that we're moving forward. So what I would say are 6 areas that particularly resonate with me. One is the looking beyond the health system building blocks with a focus on communities, and that not just a top-down approach, but a bottom-up as well, and trying to bring them together. Having equity as a central tenet, I think makes a lot of sense and brings out the need for other frameworks in connection, such as with universal health care, with primary health care emphasis that we're seeing right now. And I think also what's very exciting, and I think coming together with a lot of what we're doing in the evidence and data space, is to have a subnational focus, because increasingly those who are implementing on the ground are recognizing that even provincial level and national level data and evaluations are not sufficient, because what's happening is at the district level, and especially with decentralization going on in many countries, it is important to go down to the subnational level where action can take place. And then I was just really, really excited to have Mai mention the 3 dimensions of health system areas that she has prioritized for equity, because just literally yesterday, we had a conversation with the Gates Foundation, who funds the MAGE project, that these are precisely the 3 areas we have also prioritized for the gender and equity lens integration at GFF, resources or financing, the health workforce, and quality. And I think Mai mentioned the equity consideration, and we are looking at it in even more specific lens of gender and equity consideration. So this issue of health insurance access, for example, how many women are denied health insurance access because they don't know the system, don't have identity cards, are married to men who have insurance access but don't themselves have access, or may not have the legal marital status, or if they're not married, what do they do, or they're in the informal sector. So there's so many issues there of inequity that come up. And then, the gender dynamics in the health workforce are now really coming out. We saw through COVID, the disparities there, and the burden that women face in caretaking, both at home and in the workforce, but the compensation, the leadership, and decision making is not necessarily theirs. And they face so many challenges, from lack of equipment and training to lack of pay and harassment and so forth. So, and then respectful care is, I think, the ultimate measure of quality of care from a gender perspective. So I think these areas are very resonant, and I'm so glad to see that we're moving forward on these together. The other part I really was excited about in this framework is that it goes beyond outcomes. Getting there is as important as the outcomes that we're measuring. How is important, and focusing on the how especially in the measurement and the evidence generation that we're doing, is absolutely critical. Otherwise, we end up having this huge gap between what are commitments and policy frameworks and what actually it gets enacted on the ground. And I think this focus on implementation research, which also, again, at the GFF, we're very much focusing on and bringing in the Hopkins expertise on implementation research and learning is critical. So next slide, please. So there are definitely learning gaps to address, and I'm going to pose some of them, which I think many of you may have thought about already, but others maybe that are going to be a bit controversial. And I bring them up because, having worked in the gender and equity space for the last 25, 30 years of my career, I feel that the gender movement has learned a lot, especially from having a lot of commitments not translate into action, and backsliding on many commitments. And so often when we thought that having people being on board, organizations, ministers, private sector companies being on board and being committed to gender equality, or approaches that we have taken that are very community-based and people-based and people-centered, we have had a lot of not so positive results coming out of these. And I think that those are important lessons, experiences for us to bring to the table. Why do many rights-based approaches that we do take, equity approaches that we do take, do not pan out as we expected? I have 5 sort of questions here that I think are important for learning and evidence generation to address as we move forward, and hoping that we won't be tied within our existing frameworks, but will innovate in this space and challenge ourselves to ask the tough questions. And the first learning gap, and I think question that I would pose, is systems and community change. Should that be done simultaneously, or is service provision a precondition that is required before you start mobilizing communities? This, I think, comes from my experience with a lot of demand-side interventions that then end up getting people excited, but then there is nothing for those people to access because services just were not there, or they were really poor quality. The second question would be, what are the conditions under which bottom-up efforts influence not just policies, but the resource allocation and implementation? So as I said, from the gender movement, I've seen a lot of commitment in policy papers, a lot of tick box exercises that say, oh yes, we are behind this, but then it does not follow through with resource allocations and implementation. So even if we do mobilize communities, even if we do mobilize the actors from on the ground to convey their needs, are they going to be on paper only? A third, I think, critical issue is, when do inclusion, representation, and engagement actually lead to power and influence for those who have been excluded or marginalized, and when do they not? So I think it is important for us to remember that inclusion and representation are not necessarily the same as having power and influence. Women are not excluded. They are included in every system, every approach. They're over 50% of the world population, but that does not mean that they have power and influence. So I think that we need to keep in mind this difference between inclusion and influence, and especially power. A fourth question I think we need to consider in our learning is it adequate to consider communities as cohesive, and benign. So we do focus a lot on communities and as the channel agents for equitable change, but communities have their own power relations, and communities have their own inequities, not only in terms of income and ethnic and other power dynamics, but again, when we look at gender inequality, you have family power dynamics where communities have disparities between women and men. And it is precisely communities that themselves that reinforce and enforce gender norms or social norms that are harmful on so many fronts because there's power involved. And a lot of powerful agents within communities that we often try to target to convince them to do otherwise have a lot at stake in sticking with the status quo. So I think that this unpacking communities is an important lesson that we need to learn as we move our agenda forward. And then I think this is maybe the last question, is the first one that I started out with. Does our increased focus on communities increase actual accountability when you have corrupt political economies, or does it just give the power holders a free pass on systems change? So do they then shirk off, the power holders shirk off their responsibility and say, oh yes, the communities will take care of this. Let's focus on the behavioral change intervention. Let's change people in communities rather than changing our systems. You know, and this has come up, I think Dr. Tedros at WHO said recently in some conversation, you know, we keep trying to change women instead of changing the systems that should be accountable to them. So do we keep trying to change communities and rather than the systems that should be accountable to them? I think that those are the questions. They're not easy ones that I think that we do need to address. And I also think that in this equity bucket that we're looking at, we often, we say that we're going to look at intersecting inequities, but we often don't. And I'm actually really dismayed to find increasingly, as I see the equity lens, that people say they're looking at gender equality, but they're not, which is why somebody like me is needed at GFF to bring in the gender and equity lens. So, and this can happen with, you know, beyond the socioeconomic status, other inequities can often get lost out. And so that intersectionality is important as well. So I'll stop there, and I will be really excited to hear your thoughts on this and our panelists' thoughts in the work that they're doing on moving this, this learning agenda forward.
Wow, Anju, that was very, very powerful. Thank you so much. First of all, just very nice to see the validation that you started with, but then these questions couldn't be a better kickoff for us. So thank you very much. We'll go next to some moderated discussion with our panel. And let's see, Anju, would you like me to go ahead and introduce our panelists, or would you like to do that?
Yeah, it would be great if you can go ahead, Nathan. Please go ahead.
Great. So it's my pleasure. I think we can go to the next slide, probably. Oh, sorry, we're doing the poll now. I messed up our order.
Yeah, oh, that's right. Okay. I thought we were introducing the panelists before we do the poll, but let me first introduce the poll. I think that the organizers have constructed an initial poll to get your thoughts on what are the your interest and priorities in health system strengthening and equity issues. the first question is, what is the nature of your interest? And so it asks you about who you are. Are you a policymaker, government official, representative, or a researcher, or others? So please go ahead and click on the poll. The poll will close within 1 or 2 minutes, and there's a French version of it as well. So hopefully those who are using French interpretation can do the poll as well. And then the second question on the poll, whenever you're ready. So waiting for the first question to be over. Please take a look and answer. I'm not seeing, I thought I saw the French version of the second question, but not the first one, the English version. So the second question in the poll is, how effective do you think health system strengthening approaches in general are at promoting equitable health outcomes, with the scale of 1 being none or very little to 4 to a great extent?
Here are the results of the first poll. Are you ready to launch the second?
I think so. It looks like most people have responded to the first one.
The second has been launched.
So how effective do you think HSS approaches in general are at promoting equitable health outcomes? Not at all, very little, somewhat, or to a great extent.
We can probably go ahead and close that one.
That's good. Yes.
There we go.
Okay, so the poll 2 results, I think, are very interesting. There is most people, 65% at the somewhat category, which I guess is both encouraging and discouraging when we see that you have about 23% saying not at all and very little. So we do have a lot of work to do, and I hope that we will all be able to do it together.
Thanks so much, Anju. Thanks to everyone for taking a quick little intro poll there. So now I think we'll go ahead and proceed and introduce our panelists. Next slide. Great. So great pleasure to introduce my friend and colleague, Dr. Linda Vanotu. She's the Ghana Country Director at Results for Development. Linda is a medical doctor and a public health specialist with over 35 years of experience in healthcare provision and management in clinical and public health. As R4D's Ghana Country Director, she oversees the activities of multiple programs in Ghana, including our work under the Accelerator. And prior to joining R4D, Linda was the Regional Director of the Ghana Health Service for the Western and the Greater Accra regions in Ghana. where she supervised planning and implementation of public health activities such as immunization, disease surveillance, and control and management of disease outbreaks. She's also the founder of the Promote Maternal and Infant Survival Excellence Promise Initiative, which advocates excellence in maternal and child health and provides information and support to individuals and families to live healthy, happy, and fulfilled lives. She's the author of 4 books. And Linda, this is not in your official bio, but I will let everyone know that you have a very compelling YouTube channel that everyone should check out. So that is Dr. Linda Venuto. Welcome, Linda.
Thank you, Nathan.
And next, our next panelist is Dr. Kefi Lathbello. Kefi, welcome to you. Kefi is the head of the Health Policy and System Development at the Center for Research in Human Reproduction and Demography in Benin, Serhoud. Dr. Bello Kefi is a public health medical doctor whose work focuses on promoting evidence-informed decision-making for better access to and quality of primary health care. And she's currently doing double duty as a PhD student at the Institute of Tropical Medicine of Antwerp. And her PhD research is about the models of practice that could improve the contribution of medical doctors to primary health care in Benin. And she is very, very busy, I know, on several other research projects. I won't try to cover everything that you're doing, Kefi, but it is amazing. So thank you very much for joining us, Kefi.
Thank you, Nathan.
And finally, our colleague from ICF joins us, Dr. Susan Petrick. Susan has been a teammate of ours on the accelerator since we started, and just love working with you, Susan. Officially, she is the Health System Strengthening and Social and Behavior Change Advisor at ICF. She leads research and strategic communications projects related to vulnerable populations as part of efforts to help address health disparities, reduce food insecurity, strengthen systems, and promote behavior change. Under our accelerator project, she's been leading a body of work that you'll hear about today on research and advocacy on social accountability and behavior change approaches within health system strengthening. She also holds a leadership role under the Data for Impact project and has recently led a qualitative study in Kenya under the DHS program, focused on place of delivery and women's experiences with national level programs intended to provide free maternity care. So right up our alley for today's session. Susan, thank you very much for joining us, and thanks to all 3 of you for lending us your expertise today. So with that, I will turn it back to Anju to moderate discussion with our panelists. Over to you, Anju.
Thank you. Thank you very much, Nathan, and welcome, Linda, Kefi, and Susan. It's an honor to be on a panel with you, all 3 of you. So maybe we could start by having each of you please tell us a little bit about your recent work on promoting equity, what equity problems were at stake, and how did your work approach it? So maybe we will, each panelist will respond with just a few slides and an initial overview, and then we can go into Q&A. So can we start with Linda, please?
Yes, thank you very much. I hope you can hear me. It's a pleasure, and I'm grateful for this opportunity. Ghana is committed to ensuring that everyone living within the country has access to care. And one of the areas that has had a lot of attention because of the importance to people getting access to care is financial risk. And so mine is going to focus on ensuring financial risk protection within the country. And as an introduction, please, the next slide, just to give us a flair of what is happening. And Ghana defines the UHC as that all people living in Ghana would have timely access to high quality healthcare services, irrespective of the ability to pay and even the geographical location. and we are poised to have this done by 2030. But one of the key things that, as I said, would affect this is the financial risk that people might have. So in line with that, there's the need to look at what can be done. And this is about eliminating fiscal and financial barriers to accessing primary healthcare services, especially for those who are at risk of incurring a lot of adverse health and expenditure at the point of care. And several strategies have been tried in the past, including what we call the capitation, which unfortunately did not go the way that it was desired. However, that led to an innovative way of looking at providing healthcare, especially within the community for those who are at risk. And this is what led to the pilot of the primary care provider networks. And this is a way of providing care by networks. So health providers come together as networks, and now we refer to it as the networks of practice. Next slide, please. So the next slide can we have the next slide? Yes, so this is giving us, no, please, the previous slide. It's giving us an idea of the journey so far. And so you can see that taking it from 2017, where the Ministry of Health commissioned the primary care provider networks after the capitation had not worked the way it was expected to do. And this had the goal of maximizing efficiency in the use of resources towards improving quality of care and coverage. And it went on to 2020-21, where there was a scale up from the initial 2 pilots to 10 new districts. And then we moved on to 2022, based on work that was done to look at the pilot that had gone on with an implementation research. It led to the reorganization of the provider networks concept and the model for which these networks would work. And that was focused on strengthening the health centers, which already had been very weak in terms of the systems for delivering primary healthcare within the country. So although the capitation did not go the way it was expected, it gave an opportunity to rethink and look at the way primary healthcare can be delivered, especially at the community level. And currently we have the concept of the networks of practice as what the country is using to deliver healthcare to achieve the universal health coverage. Next slide, please. Yes, so within the equity implementation research that was done, which was the phase 1, and it was completed to look at the potential of these primary healthcare networks providing equity in terms of healthcare delivery. And some lessons were learned, there were experiences that came out. For example, there was the improvement in the selection of delivery practices. There was also seen that the use of these networks led to the teams working together as opposed to they working as individuals, and therefore helping to improve on care delivery and also the equity and access at the remotest point of healthcare delivery. Now this led on to the phase 2, which is ongoing. It's also an implementation research in new districts. And it's a new district because this is being done to get a baseline data to work with in terms of comparing this to future work that will be done to see whether the equity aspect has actually been addressed as was set out to do. Now, within this implementation research, the health insurance was seen as a significant factor in healthcare utilization. So in the remote areas where people had access and they had the health insurance card, they were able to use that to access care. It was also found that poorer households and those living in rural communities are the main clientele for the community networks. And this is also key if you want to address the issue of equity and quality of care. And then it was found that the networks created an opportunity to improve equitable coverage of services for these groups. So because there's a network and people share resources and they also share expertise and capacity, it meant that this improved access to equity and also to the quality of care that these people received. Next slide, please. Yes, so the findings from all these, as I said, have been used to redesign Ghana's primary healthcare And on the right side, by right, you see that there's this diagram there. In the middle of it is the hub, and then we have the various sectors around it. These are the small facilities like the CHIPS compound that we have in Ghana, the private health facility, the school infirmaries or sick base, all these feeding from the center, which is the hub, and these are the spokes. Now, these together from the hub will now be linked to the district hospital. And the remodeling of this, looking at how the network should function, are all based on the original plan as well as what was observed from the implementation research. And that is key for us because, as I said earlier, the health center was found to be the weakest. And now through this, they are being developed and built to the level where they can provide even a basic emergency obstetric and neonatal care, as well as address the issues of non-communicable diseases, which unfortunately are on the increase in Ghana. So these have been used to do this. Now, also underpinning all this is the fact that the country has developed the essential health service package, and therefore using the primary healthcare service package, which is there, linking it to the essential health service package, and also building the structures such that they can develop the BMOG and NCDs is helping to improve equity and access to care, even in the lowest level of care. Then again, with this, we also have the formalization of telemedicine and consultation, because as a network, people can move through the community, and people at the higher level of care can link up with those at the lower level through telemedicine and provide care to these people, even if they are not able to move to the next level. Another thing is that it helped to strengthen, to some extent, the gatekeeper system, and therefore also improved upon referral. Then one good thing that was also seen is that this is helping with resource sharing, including even human resource. So a midwife could move from one level to the other, or a physician assistant could move from one level to the other. So these are how the implementation research finds.
I'm sorry, Linda, can you hear me? Linda, we lost your sound. I don't know if it's bandwidth. You might try to.
Can you hear me?
Yes, we hear you now. You might try shutting your video. I don't know if it was bandwidth.
So I was saying that with the findings from the equity IR. Oh, okay. I think the internet connection is not stable.
We hear you well now.
The equity IR helped to remodel the networks. So these are some of the good things that were found, and these have been used to help improve upon the model of the network that is being used to deliver healthcare at the lowest level of care, leading to sharing of resources, leading to improvement in referral as well as telemedicine. And they are not just providing care, which used to be the basic ones, but improving services for BMONC, that's basic essential care for mothers and children, and also for non-communicable diseases. Next slide, please. I think that would be the last one. The network is not very good. Next slide, please. Yes. So with all that being said, this is helping to improve upon the NHIS, that's the National Health Insurance credentialing of all member facilities. Now they are going to be credentialed as one unit to help with service delivery and also with financing for healthcare delivery at that lowest level. And just a couple of days, we had a discussion with the Director General, and this is something that they are moving forward. And the other thing is about the data system support. Through this network, this is being done so that from the lowest level of care, health information would be improved. And this would help with planning and resource allocation, resource mobilization, and accountability, because then the people would know what is happening based on results. And there's also the improvement with access to the community, as well as the community working with them through the community scorecard to address some of these things. Now, currently, because of what was found out from the implementation research in the places that this were started, that place has become the model which the country is still learning from to be able to improve on the development of these networks of practice as it uses that as a tool for national scale-up to improve on universal health coverage. This will be the last slide. Thank you very much for your attention. And sorry about the network. Thank you.
Thank you very much, Linda. That was a great presentation. Thank you for giving us a very good view of some innovation that's happening in Ghana. We'll next go to Kefi, and she's going to be talking about her work, and we're excited to learn about it.
Thank you, Andrew. So good morning, good afternoon, dear participants. It's really a pleasure for me to share with you how we are trying to bring out community voices in the co-creation of health policies in Benin and more largely in West Africa. Next slide, please. So in our context, so in sub-Saharan Africa in general, but specifically in West Africa, we have more and more primary care physicians. So for those who know West Africa and Francophone Africa especially, you probably know that at primary care level, we usually have non-physician practitioners. So we now have more and more primary care physicians, and this should be an opportunity because they have the potential to improve health outcome. However, as you can see in the graph that is on the screen, there are several issues, and one of them being really inequities and inefficiencies in the way they function. So you can see that, for instance, in Benin, in rural area, population have like 7 times less chance to get access to medical doctors, to this primary care physician than those in the urban area. So we also realized that to improve the contribution to better health outcome in our context, we will need a clear policy framework, which is, let's say, inexistent in many countries. So we engage in our research program in a policymaking process that would aim at developing this policy framework for the functioning of the primary care physician in West Africa, particularly in Benin. So in our context, usually policymaking processes entails evidence gathering in a national and international setting. So we are more and more better in having evidence-informed policymaking. We also have stakeholder dialogues, but usually these dialogues happen at national level. And the problem is that it's difficult to gain actually a good knowledge on the population needs, especially the needs of people that are vulnerable or those who live in far communities or communities in rural area. And this is because we have usually top-down processes whereby experts at national level, and classically it will be a consultant that is hired at national level that will actually lead the process. And at the national level, those people participating in the dialogue, even if there is more and more efforts to include, for instance, civil society organization and various groups of stakeholders, we see that these people at the national level are not always representative of the voices of all the communities at the ground level. And also people are usually not aware on all the needs of the communities. There are also some democracy-grounded bottom-up processes. So for instance, in my country, in Benin, when the government has a new policies, they will share it with what they call what we call the social partners, which include usually the trade unions and the main civil society organization. But still, these processes are insufficient because, again, it's very difficult to ensure that they are representatives, and also that the needs of the population on the ground are well known and well shared at these instances. Next slide, please. So for the development of this policy framework to guide the primary care physicians' practices, we still gather evidences from the primary care physicians themselves, from national stakeholders, but we really aim to reach out to the community members in various settings so that we can get really voices from the ground and also voices from various group of communities. So we went in areas that were chosen purposefully in several health districts, and we had like say 16 focus group discussion with the community members, but also with other cadres of the health workforce, so including the community health workers. So because here also, even at this level, even at community level, you know, it's not always easy to ensure that the community discussion or the group discussion are not captured by the elite. So we try indeed to have a varied group of communities, so including, for instance, women association for people who are disabled, youth association, etc. But we also try to complement this focus group discussion with individual interviews so that we are able ourselves as research team to try to bring diverse opinion. Next slide, please. So as some results, so the process is still ongoing because we aim to have at the end of the month the co-creation workshop. But what we could see is that really, first of all, we could see that we really have different narratives. You know, the narrative that we were hearing at the national level is sometimes completely different from what really is going on the field and what are the needs and demands of the community members. And we can see that some specificities were highlighted. So for instance, in rural areas, people tend to visit non-physicians. So this is not very new, we knew it, but it's not actually because they don't need the physician, but it's mainly, for instance, because of some cultural issues whereby maybe the non-physician are more from the areas, and also because of, if you want to see a physician, for instance, you need to take appointment, which the people in the rural communities are not really always able to do it. Whereas in urban areas, people have more power, are more empowered to really go to the physician. So it was really now surprising that in the urban area, people really tend to prefer to go in the physician than in the urban area. Because at national level, the policymakers would say, well, in rural area, people don't really want physician, so it's not really efficient to have a physician there. So it's not that because people don't want it, it's maybe because the way the physicians are practicing, the way the physicians are appointed is really different from what people really need. So we are using now the results for a bottom-up processes in the development of this policy framework. But still, what I would like to share also, at least with this audience, is that still, despite all this effort, we are really aware that there should be a continuous effort, because this should not be like a one-time to go to the community to gather the evidence. We should really try to find the ways to have a really regular way to engage the communities. And also, I like for instance, the idea of really putting also some power within the community members so that they can access and they can also really have social accountability mechanisms so that they can have better access to this primary care physician. So we expect that all this will be really taken account in the final policy framework that will be developed. Thank you, and over to you, Andrew.
Thank you, Kefi. Such an interesting presentation, and we hope that your work goes beyond Benin. There are so many interesting findings here. So last but not least, we'll turn to Susan, who's going to be talking about improving linkages between social accountability and social and behavioral change, which are two of the pillars in the framework that the Vision 2030 that we saw earlier. Over to you, Susan.
Great, thanks, Andrew. Thanks everyone for joining us today. It's really great to be here and be part of this panel. So as has been mentioned, I lead an activity under the Health System Strengthening Accelerator Project. It's called Improving Linkages Between Social Accountability and Social Behavior Change. And since that's really a long title, we do often refer to it as SASBC linkages, just to shorten it a bit. It's a small activity, but also one with large ambitions around raising awareness and sort of promoting new opportunities for more behavioral centered programming. So next slide. And increasingly, I like to think of this activity as it's been ongoing for several years now, to think of the activity something like I might call a research engagement activity. And by that, I mean the activity began by conducting a small study in 2020. We undertook data collection with stakeholders in Cote d'Ivoire, Ghana, and Guinea through an online survey and virtual interviews. The aim of that study and the activity overall is to consider two prominent practice areas: social accountability, or social and behavior change, and social accountability, and think about where there's overlap and what synergies can be mobilized. So some of the key takeaways from the study include that generally there were mixed views about if and how social accountability is prioritized by national governments. Many study participants noted that government support and citizen advocacy are two keys to the success of social accountability. The participants appeared to view behavior change from the government and citizens as linked, in asserting that government must change its behavior and better inform citizens of their rights, and citizens must change their behavior to exercise their rights. The activity is focused on raising new questions and encouraging new ways of thinking. And we've been interested to understand if the implementation of social accountability activities includes the integration of behavior change goals. And if so, how does that work? There's also a lot of social accountability work that centers on efforts to advance UHC, particularly in West Africa. So it's the same question. How can you apply a behavior change lens to that work? We feel that this activity considers equity and promotes equity. Our focus revolves around thinking of social and behavior change in terms of government actors, health system actors, and citizen actors. And where are there sites among those actors for behavior change? And we're also asking whose behavior must change and how does that change relate to government, institutional, and procedural change? We want to be mindful of how information, policies, plans, engagements flow, and who is included and who is not. Next slide. With the study, our approach has been to look at specific findings and then engage with specific sets of stakeholders in relation to those findings. So in this slide, on the far left in red, I have noted some of the findings from the study in relation to challenges with social accountability in support of efforts to advance UHC. And some of the challenges that were identified include that the efforts to advance UHC tend to be top-down, and that there are few pathways for involving citizens. And often the notion of demanding social accountability is seen as culturally unacceptable. So in the middle column in dark gray, I noted the country engagement we've pursued in relation to these findings. Then on the far right, in the light gray, I have noted the type of equity-related challenge we are seeking to move away from. And so the first research engagement activity focused on disseminating the findings from the studies. And so for stakeholders in Cote d'Ivoire, Ghana, Guinea, we held 8 subnational sessions to discuss social accountability, UHC, and how to apply a behavior change lens. Among the numerous aims of these sessions was moving away from situations where research findings and discussions of the information never makes it past the capital city. We included more people and specifically subnational stakeholders who sometimes get left out. The next research engagement activity was to hold a workshop for the Togolese UHC task force and selected CSOs. The key output was action items that consider the different actors and related behavioral perspectives. Here we were seeking to help the workshop participants increase their understanding of how behavior change might be needed across government, health system, and citizen actors. The third research engagement activity is that we are developing a tool to guide budget advocacy work with inclusion of a behavioral lens. Budget advocacy is a common social accountability activity, but in developing the tool, we are trying to move away from quick dismissal and not realizing that national procedures such as budget planning are sites to seek increased inclusivity and any related behavior change. So that gives just sort of a brief overview of this activity and our sort of focus on social accountability and social behavior change and the ways that these two are linked and the ways that we can cast an equity lens on this work. So thanks so much. And I turn back over to Anju.
Thank you, Susan. It's good to have a multi-country study and analysis that has been going on for some time to accumulate learning from that. So as I turn to questions that I will be posing in discussion with the panelists, it would be great if all of you in the audience could also post your questions and your comments in the Q&A box at the bottom of your screens. And then we will, the organizers will send those questions my way so that I can pose them on your behalf to the panelists. And of course, you're welcome to ask me questions as well, although I'm not presenting the expert work that these panelists are. So you're highly encouraged to use that Q&A box for questions that you'd like to pose. So after that rich discussion, maybe I will start with Linda. Linda, are you still online and is your internet working okay?
Yeah, I'm still here if you can hear me.
So one of the things that interested me very much in your presentation was that you started out by talking about this network approach by saying that the capitation approach had not worked. And I thought it would be good to hear from you. We often tend to highlight things that have worked. We do analysis and research that says this has worked and that has worked. But I think it's so important to also highlight what has not worked. And so I was wondering if you could tell us a little bit about why the capitation approach had not worked. And just for those of you who don't know what a capitation approach is, it's usually a way providers are paid for the services that they deliver by placing a cap on the amount that they will get based on the number of clients that they serve. But Linda, please feel free to elaborate on that. And what would be also interesting is if you have any insights on how the new health insurance or the movement on the health insurance scheme will be looking at not to repeat the mistakes of the capitation approach, because as many of you in the US know, we have a capitation approach in the US health system with Medicare, Medicaid, health insurance, and that can create problems. So please, Linda, let's talk a little bit more about that.
Okay, thank you very much. For me, it did not work, not because it is not a viable or good model of health financing. I think that it was all because of where it was introduced or started from, and the understanding that the public did not get, as well as the healthcare providers. Just on Friday, we had a meeting and we went a bit into this discussion. So it is not that it's not good in our system, because one of the things that could have done would have been to also promote health, not just for clinical care, but even for the prevention and promotion of health. That is a good thing. I think that did not work because for me, it did not go out so well. The people, that's the public, the healthcare provider, they did not really understand, and they didn't even try to test it to see how it would be. If you look at the networks as they are now, I think that is one of the key things that would be helpful to test it and see. And this is something that is being looked at, because as it is now, these networks are a group of health providers. Most of the time, they are these small facilities at the lowest level. The amount of money they generate is quite small. But if they have this, that we are giving you so much, and we are giving a part of it to you upfront, which they can use to improve upon the services, including prevention and promotion, that would be helpful. So I think that now what we're doing is going back, looking at the implementation, looking at all the things that went into that. Why is it that it did not work? And again, there was also the political factor, which is a big thing if you want to talk about it. But that is one of the things that also played a role in it, in not helping it to work. But the concept itself and what it can do in terms of improving equity and quality of care is good. And it's something that we need to look at. In terms of the new financing, especially putting the health facilities together as one of the things the country is doing is trying to get them to be registered as a unit. Mm-hmm. Once they are registered as a unit, then they can be paid as a unit. But till that time, each of them is getting its own bill submitted to the health insurance, and they are being paid as individual units. And the way they are helping each other is that they are supporting in terms of putting their bills together to reduce the rate of rejection. So if they send them to the NHIA, then the rate of rejection is lower, then individual facilities are paid. But at the next level, they're looking at how they can be paid as one. And this is where the discussion is going on. And that means that the Health Facility Regulatory Authority that credentials facilities to function as hospitals or health centers is going to see them as one and give them accreditation as one, so health insurance can now pay them as one.
Yeah, that's a fascinating story, because I think what it actually highlights is that there's an inequity issue, not just among the population of a country that's trying to access health services, but the health service structure itself is inequitable. So the community health systems are less privileged in terms of getting the kind of resources and services that they should be getting, and they're not really on the policy mapping. And especially if we're going to improve primary health care services and the basic needs services for people, then these service provision centers and creating networks and creating clout for them, creating an identity for them is important, because they're the ones that need the resources. Because I was also fascinated by your comment that, the services weren't there. I mean, the services are lacking. And so increasing the service level is important. And unless these facilities, these providers are recognized part of the system and legitimate part of the system, they're not going to get the resources to do that. So I found your absolutely fascinating. So I was wanted to move to Kefi, also from her very interesting insight, I think, in your work. And this whole issue of which comes first, supply or demand, which I had highlighted in my presentation, but you find that, this issue of lack of rural physicians, the interpretation has been that rural people don't want to go to the physicians first, whereas your findings are really showing they're actually responding to the fact that there either aren't physicians or it's so difficult to get to one. So it's really supply driving the demand rather than the other way around. I just wondered, did your research have any thoughts on how to practically correct this imbalance of rural physicians? Especially in terms of having more physician pipeline coming from local areas, because people do, as you said, prefer to go to people from their local areas, more physicians being motivated to work in rural areas. So any thoughts on that part of your work, Kefi, would be really wonderful.
Okay, thank you, Andrew. And really, just to say that I really liked a sentence from you that I noted. So let's not try to change people, let's try to change our systems. And I think this is really, really important if we want to enhance health outcomes, especially equity. So in terms of, well, we are now discussing, and we hope that our insights will really try to show, that it's necessary to work on retaining and sending also physicians in rural area. So now the government is trying to increase the number of physicians, of primary care physicians, but I think there is a slight mistake because they are choosing as a factor, let's say, health facilities that are in bigger, that have big population, which are mostly in urban area. But I think they are open to suggestion. And what is interesting is that on the field, we really found interesting practices. So for instance, in the north part of Benin, so if university, the faculty of medicine there really try to, let's say, getting people, students in the training, they really try to also take people coming from some particular area. And also during the training, they are really trying to expose the physician in the rural, in practices in rural areas, and supporting also a program that helps some physicians to work in rural area. Well, this is not very big. Currently, for instance, we only have like 20 of such doctors in Benin, but I think these are good practices that we can really highlight and bring into to show, look, there are ways that we can really do to have more physicians in rural areas. So this is what I can say. Thank you.
Thank you, Kefi. Susan, turning to you, one of the, I think, really in trying to connect social accountability and social and behavioral change communication is sort of, again, in light with a little bit of what Kefi's research found, that, what was taken to be a norm about people or preference people had about physicians. Your findings show that social accountability is not seen as culturally acceptable. And I was wondering again here, where's the chicken and where's the egg? Because is social accountability not culturally acceptable? And that's why good social accountability systems are not happening? Or is it that social accountability has not become culturally acceptable because people really are fed up and have no expectation that they will be heard, and that they know that they're part of a power system where their voice is not going to carry, and therefore social accountability has not become culturally acceptable? And I wonder if you had any insight or thoughts on that.
Sure. I mean, that's a big and complicated question, and yeah, the chicken and egg analogy is sort of a good one to think, like, where do you focus your energy in terms of, you focus on the design of the social accountability activity, or do you sort of focus on engaging people to empower them, that they believe that they do have a voice and their voice matters, and that voice can translate to having a role in decision-making processes. And I mean, I think that, that's sort of where the link of behavior change comes in the idea that both sides have to change their behavior. You have to think of at, the level where social accountability activities are designed and planned and who they target, that you're looking at the way that actors within the government and actors within the health system, and trying to acknowledge that people in power, that they have to change their behavior. And as opposed to just thinking that, simply social accountability is a matter of communicating information to people at a community level that will prompt them to change their behavior. There's a different set of ways that change has to happen within the system and within individuals.
So I'm wondering, I mean, you're a social and behavioral change expert, and in this space of social accountability and SBC, is there a movement to actually look at the power dynamics? Because really, why should those people in power have any motivation to change the power structure? They're benefiting from it, right? So what is it that, which is why a lot of social accountability mechanisms turn into just information provision rather than response to needs and dialogue. So I was just wondering if that field of research is evolving to look at power dynamics more substantially. I mean, my experiences from social norms or gender norms research, which proposes that it's looking at power relations, but it really isn't. It's mostly, most of it is about information and messaging. So just wondered a little bit about how the field is evolving.
Well, I think that, people in the development space, I think we do look at power dynamics. But looking at power dynamics is not the same as being able to do something about changing them. You can identify where there are unequal distribution of power, and I think that we're good at making those identifications. But then trying to change that is a much harder challenge. And I think that more and more you see like projects such as the Accelerator and other health system strengthening projects, other projects funded by USAID, other donors, really focused on sort of locally led development, locally led solutions, locally led, decisions to try to change power. Like that's where that change has to come from within a country, within that government. I don't carry much weight to advocate that the government of Guinea or the government of Cote d'Ivoire, or the government of Ghana, that they have to change their behavior. That has to come from within those government systems. And so we can make those suggestions, but we have to really try to shift the design and implementation into that individual country.
Kefi, I wonder if I could go to you to follow up on that. The work that you are doing with the communities, what are some of the strategies that you're adapting or the communities are suggesting so that their needs and their recommendations are actually carried up the chain? And I also just wondered, in Benin, is it taking it to the central government, or so at a lower level, is there decentralization? Like, which part of the government does this need to be taken to? So your thoughts on that would be really, really helpful.
Thank you. Maybe I will start with the last part of your question. So in Benin, we have decentralization, but it's more the concentration. So there is still the National Ministry of Health with regional and district health offices. So usually the policy are made at the national level. And well, I think, as I was saying in my presentation, so I think also our role also as researcher, but also, let's say, policy entrepreneurs would really be to try to make sure at least to bring this insight, from the communities. And I think this is also where I see also the role of civil societies that are at the national level, because at if anything, they can still really try to monitor and to see if these recommendations are really taken into account into policy making process. And the third thing I can say that I think also maybe what makes it a little bit more easier for me and for my colleagues as researchers is the fact that we are also part of the communities, embedded in the communities also, even if we are not from all the parts of Benin, we have teams that are in many parts. So we are there, and hopefully we will be there for years and really try to connect the link and to see, okay, let not it be like one-time data collection and we that's all, but really try to follow up the progress and try to see in few months or years where we are. And I think this can maybe be helpful to make sure that really the voices are taken into account.
Yeah, I think the local coalition building between researchers, communities, and civil society organizations, academics becomes really, really important. I was wondering if, Linda, I could turn to you about what is some of the innovation in that space in sort of this, the kind of local actors, national actors who are participating in research and policy design, and the kind of research that you're undertaking. And I'm also channeling some of the questions coming in on the line here, mixture of quantitative, qualitative, mixed methods, but also defining the topics that you are going to measure, the strength of the network, the progress of the network, and its positioning. Can you tell us a little bit about, in Ghana, what kind of good innovation is happening in the collaboration between policymakers, implementers, research, and the kind of program and research designs you're having?
Sure, very interesting. Yeah, that was found to be a very good foundation for the networks to work. So you know that in Ghana, just as we have in Benin, we have the very well-structured system from the national to the lowest level, which is the sub-district level. And the policy is made at the national level, but implementation takes place at the sub-national level. And academia is brought in with research, for example. We work with academia. So that academicians are part of it, the research, the design of the research, the questions to ask, and everything to do with that. And then the analysis and interpretation are also done together. Now, the good thing with the network is that from the Ministry of Health level, we have people there who are part of technical working group. We have people from the Ghana Health Service, which is the largest agency. We have people from the other agencies, including what we call the Christian Health Association of Ghana. That is like the second largest agency for healthcare delivery, including even the training or the teaching hospitals. And then we have civil society working with them as well. We have people at the regional and the district levels also coming together. So this team, which is a group, covers everybody, so that when they have any discussions, everyone's voice is brought on board. Sometimes they even engage with the civil society. So they bring the voice of the people. For example, the dissemination that Susan conducted in Ghana, we had civil society organizations. And during that time, they also voiced out what they did not know, which means that they had been left out in developing this. Now, when it comes to, and I think I saw one of the questions, when it comes to monitoring of these things, whether they are indicators, yes, there are indicators. Within the health information system, we have indicators that kind of track access to vulnerable groups. So you take women, how many pregnant women are having access to antenatal care based on WHO, number of times and all that, how many people are having access to skilled delivery. And that is why in the slides, I talked about the EMOG, that is one thing. And before the Ghana Health Service, decided on using the health center as the hub with the spokes, which are including the sick base from the schools and the rest. They had actually done an analysis to identify the gaps within the system for such services provision, all in the bid to improve on equity and also bring on board the community's voice. They have added the scorecard, which takes that into account. So you find that in implementing the networks of practice, it's a whole group. Because if Ghana is going to use this as the vehicle for delivering universal health coverage, then it's important that everybody who has to be part of it is part of it. And that is how it is being done. Yes, and we use both the qualitative and the quantitative methods to do the research. Because with the qualitative, then you are able to hear from the people whether the networks as they had been started were actually addressing their needs. And that is why the findings from the IR are actually being used to now improve upon the model of the networks. So how should they be implemented so that they will address some of the issues that came out of the implementation research to make it more acceptable and more equitable in terms of service delivery. So that is how Ghana is doing it now.
Thank you so much, Linda. I see one of the questions online that Tom Newton-Lewis has asked is one of the challenges of social accountability of frontline service providers is that it holds accountable those with little agency over their performance due to system level constraints. It can also reinforce the unfair sense that they are the problem, and e.g. Punitive management can occur as a result. Are you aware of good interventions that target social accountability at a higher level of those who have more agency? It's a great question, Tom. And also from a gender and equity lens, we find that it's often female community health providers who are overloaded, underpaid, who are being constantly trained and held accountable for things that are out of their control. I think Kefi would like to address this question, so I'm going to turn it over to her.
Okay, thank you. And thank you, Tom, really for raising this question. I think in the work we are doing in my research institution, we are now really trying to take a more systemic approach, because so an example is, for instance, the audits of maternal deaths in health facilities. So at the beginning, we started, with the Ministry of Health supporting them to promote audits and also trying to find how to solve the problems that are found at facility levels. But more and more, we saw that this at a point is difficult, even if we are trying to hold the health let's say workers accountable. Many things goes beyond what they can do. So I think we now try, and also for other issues, and like, for instance, the complaint system from the communities in the health facilities, we are trying now not to only stay to the health facilities, but really trying to have a more systemic view, trying to work with some multi-sectoral committees, so which includes not only people from the health facilities, but also people at the national level, because and I think when you really try to do seriously the root cause analysis, you can see that many things are really, to be solved, not at only at the health facilities level, but maybe in the larger community or at national level. And the second thing I want to highlight here is also the term of accountability. So in French, we say redevabilité. And I can tell you, when you talk of redevabilité, the policymakers, everybody is scared, and everybody's like, well, this is, for for punishment and I think we are now pledging and advocating for a less heavy definition of accountability for us, and we are doing now work really trying to deconstruct actually this view of accountability. Accountability should be seen as a tool, that we use for dialogue. So it's not like community members I don't know, shouting or punishing the health workers, or it's really a tool for community members and health workers to work together. So trying to see, for instance, if the health workers have the right, a clear objective, statement, the right capacities, the right feedback mechanism, and really trying to see how we can work to improve all these, instead of just pointing, oh, you are doing bad, you are not doing well. So I think we really advocate this view of accountability as not a punishment, but really a tool for improving the performance. So thank you.
Great. Kefi, that's such an important point, because we have so much emphasis on performance measures, performance tracking, performance-based financing. We are trying to improve HMIS systems so we can track data better, and often a lot of it continues to be poor quality because either people are not entering it right, or people are rigging the data because they don't want to be punished. And there's a stream of research that is emerging very clearly that punitive measures for performance do not pay off. In fact, they make things go underground, or they lead to that lip service mechanism. Whereas incentivized performance measures, if you are going to give somebody positive rewards for doing well rather than take something away from them. And, in fact, I also wonder, the performance-based systems that actually say providers will only get paid based on X level of performance. Imagine at your own job, if you're only going to be paid at depending on different levels of performance every month, how are you going to pay your rent? How are you going to feed your children on bad months? And sometimes the performance, it doesn't depend on you, it depends on other people around you. So there are lots of very, I think, challenging ways that we're trying to interpret these approaches, and we have to come to terms with better measurement systems, better tracking, and better accountability systems. And I was wondering, Susan, do you have any, could you shed some light on improvements in indicators and measures in this space on accountability? Are there equity tracer indicators that are emerging that we should be looking out for? What is the evolution in that space?
To be honest, our research really hasn't focused much on indicators. So I'm not sure I'm in the best position to answer that question. But I guess the quick thing I would say is that, I think in the way that question was originally posed in the Q&A, was talking about different, research methods and things. And, I'm an anthropologist and believe very strongly in the value and power of qualitative research. And so I'm often frustrated that, indicators count things and they're a metric. And that really doesn't tell the whole story. It doesn't get at why something is or is not working, why something is fair or unfair. It's just a numeric representation. And so I think it's really important that indicators be complemented, sort of with the story behind that number, and get, whether it be through, sometimes you see things in reports called success stories or some kind of demonstration of what happened and why. And I think a good example is, this idea of inclusivity or participation. It can't really just be the number of people. You have to really try to have a critical engagement in whether or not that participation was meaningful for that person, and as opposed to just being something that we get to count. And so I think with our subnational dissemination, we had 8 sessions. We pulled in about 300 people, and we're really trying. And I think in all sort of dissemination sessions or any kind of engagement session, We should really budget in time to reach out to participants afterwards to ask them, was participating in this session meaningful to you? Why or why not? And try to find out the answer to that question and what story goes with whether or not it was meaningful, and to make adjustments accordingly.
Thank you. Linda, I wanted to turn to you a little bit as a follow-up to both Tom's question and another question that Lear Miller has posed in the online chat, noting that given my earlier point that often donors and programs tick the box on community engagement but don't fund it, or the same for gender integration. As implementers and researchers, what are effective strategies to move away from lip service to more substantive resource and capacity allocation? And let me maybe direct this question even a little bit more specifically. Kefi said that, you know, when you're trying to hold people accountable or look at what's happening with services, you don't want to blame that frontline provider for everything, and you start looking at root causes. Often the root causes of inequity are many, and they are not easy to change. That's why they're root causes, right? But what I have found in my work is that if we try to change them all at once, we almost certainly fail. If we put all the big changes that we need on the table, especially with under-resourced health systems, where countries that are trying to build health systems may only have, you know, a very small percentage of the financing that they need to do set, a very small percentage of the adequate people capacity to do so. I was wondering, so I find that focusing on one or two catalytic areas that are going to be really powerful is more helpful than trying to do everything. And I was wondering what your thought is, what your experience is from the network approach that you've been building, from where the health insurance policy is going next. What is your experience in trying to do too many things versus trying to do a few key things that are going to move the equity agenda forward?
Yes, thank you very much, Angie. I think that is a very important point. You know, before we blame the frontline workers, we should look at whether they have been given everything that they need to run their services. Just a couple of days ago, they were showing what Ghana calls the chips on TV, and some of the places that they showed, I don't see how we can ask those people to answer why their performances are the way they are, because they lacked very basic things to work with. So I think that to be fair to everyone, it should not just be such a broad thing. It shouldn't be a blanket thing, like whatever is used in the urban area is the same thing that is used in the rural area to measure performance or to even measure accountability. I think one of the areas that countries probably haven't focused so much on are the local systems, as you said, or the community systems that are available and which the communities are used to, that the health sector can also fall on to improve on healthcare. And I'll give you an example. Some time back when I was the regional director somewhere, we had issues with maternal mortality. And so together we looked at the region where I was the regional director and realized that we couldn't use one answer to address everything. So specifically for each of the districts that were within the region, they were to identify their own reasons why they had the performance as they did, and also find out what were the resources within the communities and the districts that they could use to address the specific challenges that they had. And when we did that, we saw a marked change. So even though we can do something at the global level, national and regional level, even district level, there are these areas that have to come in. And I think that for me, in my experience working within the health system, that is an area which we haven't focused so much on. So the root cause analysis should also be linked to the community things that are available, things that they can use, which probably may not need to get extra money, and for which we can use the level of capacity that we have within the communities to address those issues, including the community members and the community structures, which are acceptable to them. If we are going to do polio immunization, for example, we work with the community and we get results. We can get up to 90% coverage or even more using the communities to support this intervention. Unfortunately, when it comes to other aspects of health, we leave them aside and try to bring in our own root cause analysis and our own answers to those causes. In terms of how we are tracking these, we have, of course, within the health information system, some of the indicators that are linked to the performance to make sure that there's equity. And so that is what is done. But in addition to that, in Ghana, we also have what we call the peer review, which helps one hospital to peer review another one, and the other one does the same. And that, for me, is also another way of improving on social accountability. The other thing that is done is about signing of performance between the Director General and the regional directors and the district directors. So you said you were going to do this. Now, at the end of the day, it's looked at to see whether you're able to do it. But of course, they also state what they would need for them to be able to perform as expected of them. So it's a whole mix of things which I believe need to be looked at holistically to bring out the issues and also bring out some solutions, but including community systems and community structures and community resources that are available. Thank you.
Thank you, Linda. Susan, I was wondering, you talked about budget advocacy emerging from your research. I know that certainly in the gender field, gender budgeting is an important tool for trying to make policy commitments real. And as countries are decentralizing, budget advocacy is needed and I think what Linda is saying, to community-specific needs. Can you tell us a little bit more about what that budget advocacy emerging from your research looks like, and where did it lead?
Sure. I mean, I think budget advocacy is a common social accountability approach or tool or activity. And, you know, similar to the question that was asked earlier, it is one that focuses at a higher level. It can be a bit different than social accountability that is more about community engagement. Budget advocacy is really a platform for citizens to understand the budget process and to intervene at key points. And so I think it's sort of good in that sense of it's not as focused on healthcare providers. It's focused at the systemic level. And so when we completed our research, we were able sort of to connect with another activity under the Health Systems Strengthening Accelerator project that is working to help help in the implementation of a community health plan in Guinea. And so we sort of made that connection there and sort of made a small contribution to that larger activity by just in the sense of designing a tool that could be used by citizens and citizen groups as this community health strategy is rolled out, and sort of thinking, okay, this tool would help them to understand first what the community health policy is, and to understand the budgeting process and understand what are the entry points of where decisions get made about how community health programs are designed, how they're prioritized, what communities are the focus, and a range of other questions. And so some of it is, it's a tool to help people understand the process of a policy, but also at key moments, understanding where they can step in as in an advocacy role, and where they can step in and think about changing their own behavior to be more advocates, and changing and working to change the behavior of government officials to accept their advocacy. So trying to think of that idea that any kind of endeavor you undertake in budget advocacy work or any sort of any engagement type of activity, there's always a set of people, including yourself, where behavior change is possible. And just to be open to that idea that behaviors can change.
Thanks, Susan. And the more I think about it, I think that in some of the work that we do at the GFF and the World Bank and sort of building financial management capacity in countries, doing that at the decentralized level. So it's not just people, but also health system workers and decision makers at the more decentralized level need to understand how they can manage their budgets better and be able to achieve the outcomes that procurement and human resources and so forth in ways that are more equitable. Somebody had posed the question in the chat that, you know, with rising inflation, how are you supposed to meet the costs of all the things that are needed in the health system? It only makes the challenge worse. And I think that this lack of recognition that we are working with very limited resources in many countries and have to make the best of it. Of course, governments need to allocate more domestic resources to health, but their tax systems are weak. If we want to wean away from donor funding for doing domestic health resourcing, we have to find creative ways for doing that. And there is, I think, this issue of task shifting. If we keep shifting higher level tasks because we don't have providers to lower level providers who often are coming from the more disadvantaged groups like women and like poorer families, then we're shifting the task to them. And in many cases, we're shifting the task all the way to families. And where again, women are the ones who are going to do that caretaking of health. So there is this, health systems do get a free ride from the extent of work that you task a shift down. Maybe sort of just a last quick question, Kefi, to you. I was actually really interested and intrigued in how you integrated a gender dimension into your research, and really pleased to see that was a very core element of the equity analysis you were doing. And I just wondered what led you to think in that way, and how can you encourage others to weave in that dimension on a more regular basis?
I think, well, the obvious answer is that I am also a woman dealing also with some key issues. So, okay, even if I'm among the most lucky one, but I think really we are more and more, at least in my context, aware that we really need to look at the specific needs of the women. And also when I think in every setting, the women are the one using more the health facilities. So we really need to have the voices when we want to look at what is happening there. And I think, well, this is something we can just keep, advocating for, trying really in all of our analysis to have this type of disaggregated data, and also even in the way we are engaging or we are selecting the research participant, trying to keep this balance, in genders. And I think also maybe something that can be helpful is also building local capacities, because what helped me also is that I was working with also assistant and researchers that are really well-versed, in gender issues and also in community engagement. So I think also building local capacities can also help doing that.
Thank you, Kefi. So we're almost out of time, and I wonder if I can just give each of you 30 seconds to sort of say one or two sentences of your takeaway from our meeting today. Maybe start with Linda.
Thank you very much. First of all, thank you so much. It's been a pleasure listening and learning from all the discussions that have gone on. I think that when we think about equity, we should think systemically. We should think about the end user, but also include yourself. Because if we have equity, you may one day find yourself at the other side where you would need that help. So that is what I would say, that think about everyone. Think about yourself as being one of those people who need to have equity in the care that is provided by the country. Thank you.
Thank you. Yeah, empathy is a very important, important feature. Susan?
Sure. I think, I would just conclude by saying, a lot of my work as, under this activity is really, becomes very UHC focused. And I think it's important to just remember that, like UHC and equity, they're really quite similar. They have, there's a really strong overlap in the sense that you're trying to, to develop a health system that has greater equity, that has a greater level of social consciousness. And so I think that we even in not specifically always focusing on UHC in a lot of ways, that is centrally what we're thinking about. And so I think that that's quite important to remember.
Thank you. Kathy?
Okay, thank you. So I think my last thought is that when we talk of equity, it's also about rearranging powers and also redistributing privileges. So let's not forget the political economy aspects of all our intervention, and let's try really to be open to this and try to make more structural changes, even if they are very, very small at a time. Thank you.
Thank you. Thank you, Kathy. I think you're echoing sort of my mindset as well. I think you have to keep the political economy in mind as you're working. I think that there's a lot of power that you can see from good models at the local level that are emerging, and then you can see how they can be adapted to other situations. There's a lot, I think, going on there. I think financial tracking, which I know that actually USAID and our leader now there on health systems has been doing a lot of work on that. So I think that Maya and others can show how the money, how the money moves and how responsibilities move has a lot to do with where achieving success going forward as well. So thank you everybody for a great session, and I will turn it over to Nathan to conclude.
Thank you so much. This was such a fantastic session. I just really loved every minute of it. As someone who studied the politics of health reform, I really valued that last point. I think that, by the way, is going to be a major theme at in various sessions across HSR in Bogota this year. Thank you so much. Anju, thank you for giving us these 5 excellent, tough questions to begin with. Thank you, Linda, Susan, Kefi, for sharing your expertise and insights. Thank you to Mai Hijazi and Jody Charles and Jesse Joseph and Neetu Hariharan all joined us from the Office of Health Systems and USAID's Global Health Bureau today. I probably missed a few others, but thank you to USAID for this. And most of all, thank you all for joining the discussion today. 2 hours is a lot of time out of anyone's day. And we really appreciate you sharing that time with us. So thank you very much. This is going to be a big theme for us going forward. Lots of great questions raised today. If any of you have follow-up questions or would like to connect with us or any of our panelists on this kind of work, you can see a point of contact there on the screen. You can contact my colleague Leah Ewald at that email. There's also our project website, which is accelerate.hss.org. And the last thing I would say is I believe it is true, I'm 99% confident that we will be posting the recording of this session on our Accelerator website soon. So if you have colleagues that you think should see parts of it or all of it, please feel free to share that once we'll try to send the communication out once that is available. It may take just a little bit of time. So thank you very much, and please join me virtually from around the world in giving our panelists a great big round of applause. Thank you all. Goodbye.
Bye-bye.
Thank you. Bye.
Thank you, everyone.
Thank you.
Bye.
Bye.